Okay. Good evening, and I welcome you all for the webinar on evidence-based approach to managing PCOS. I think Sri Lanka College of Obstetrician and Gynecologists, SLCOG, and we strongly believe that's our responsibility to train our junior staff. And further, so it's very important to help our membership to update their knowledge in par with new evidence. And however, that's not for anything, so betterment of women in Sri Lanka. And as our membership is very much tied up with their clinical commitments, I think this would be a good approach to share the knowledge, because we can reach majority of our membership. And today our panelists are very eminent characters in their respective fields. And I welcome Professor Helena Teed. And she's, despite with her very busy schedule, and she was so kind to accept our request, even with short notice. I welcome you, madam. And Professor Chandrika Vijayaratna, ma'am, so I welcome you, because she was very instrumental in arranging this webinar right from the beginning. And Dr. Udara Jayawardena, and again, specialist in subfertility. And he's very kind, because he helps our membership and in whatever the webinars or other teaching sessions and relevant to his field. And further, I welcome our colleagues from our sister college and College of Endocrinologists, and our own membership, and our trainees. And I think without wasting our time, I think it's time to start our session. And I invite our president, Dr. Mangala Disanayaka. So it's that for the brief introduction of our main speaker, Professor Helena Teed. Thank you.
Good evening, ladies and gentlemen. My name is Dr. Mangala Disanayaka, President, Sri Lanka College of Obstetrician and Gynecologists. So again, welcome for this webinar on evidence-based approach to managing PCOS. International Guideline 2023. It's my pleasure and honor to introduce the first speaker, Ms. Professor Helena Teed. She's a clinical endocrinologist. Professor Teed is the Director of Monash Center of Health Research and Education, Monash University, and an endocrinologist at Monash Health, who holds an Order of Australia for services to women's health. She's a fellow of Royal College of Obstetrician and Gynecologists and fellow of Wellstock. In addition, she's honorary professor of women's health, University of Birmingham, honorary professor of healthcare improvement, University of Wall, and international advisory board member in NIHR, applied research collaboration is equal. And her main interest is on polycystic ovarian disease, diabetes, metabolic health, and in addition, leadership and equity, implementation of science and data-driven healthcare improvement. And most importantly, she is consultant lead of this International PCOS Guideline 2023. Please welcome Professor Helena Teed. She's going to talk on our polycystic ovarian challenges in adolescence. So with you, madam.
Thank you very much. Hopefully you can hear me and see the slides well. I'm coming to you from Ireland, even though I'm Australian, because I'm over with collaborators at present. And I'm going to talk to you about the international evidence-based guideline with a lens around some of the challenges we see in adolescents. Just to highlight, as you can see here, that there were many lead partners in this guideline, and indeed I'll share the partners around the world shortly. I have no conflicts, I receive no pharma funding, and all my funding comes from competitive government grants. These are the core societies who participated in the guideline process, including ASPIRE and also the Asian Pacific Pediatric Endocrine Society and also the PCOS Society of India. There was regional representation from 6 continents. Just to remind everyone, evidence-based guidelines are different to clinical consensus statements and are different to just evidence synthesis or Cochrane reviews. They take the best evidence from research, which sometimes is adequate to give us very clear evidence-based recommendations, but not always. They also take multidisciplinary clinical expertise, and ideally that should be global, so we can take the perspectives of different ethnic groups, different healthcare settings into consideration. We also take in the consumer perspective, and that's taken very seriously throughout the process. In this case, the guideline topics and the outcomes were determined by over 3,000 women from around the world affected by this condition. And we also consider cost. All of those factors are considered in a rigorous process to generate the recommendations. We go through a process, and this one slide is about 2 years of my life, but essentially we establish the guideline development groups and agree on the scope. That included engaging with those 3,000 women on surveys and workshops, and also with health professionals nominated by the relevant societies. And Chandrika, who is on this panel here, it was actually a member of this process. We then undertake extensive systematic reviews, and in this case, there were 55 systematic reviews on evidence that informed the guideline. We then undertake very robust and transparent guideline development and formulate guidance, and then undertake dissemination, of which activities like these are very important. So that we know the guidelines are developed in the most robust way and avoid simple opinion, but actually do rely on evidence and have perspectives of healthcare providers and those affected, we use a very transparent process. That includes the agree process, where we look at the level of evidence, whether it's high, moderate, or low, or very low, and then we generate either evidence-based recommendations. Where there's not evidence, we'll have consensus recommendations and then practice points. But importantly, it's not just the evidence. We also use the grade process, which is a document where all of the guideline development group members, and there were 70 in total, but around 10 to 15 on each guideline group, consider the evidence quality, but they also consider, is the recommendation feasible? Is it acceptable? How much will it cost? Will it increase inequity? Will it be something we can implement? We consider all of those before we come up with the strength of the recommendation. The actual guideline is readily available online. If you search Monash PCOS, it's freely available. And very shortly, the research roadmap will also be available. It's published in 4 major journals, and the evidence synthesis and systematic reviews are also available online, and there are around 20 so far that have been published. All of this is available freely. So just let's touch on what we know about this condition, and that's going to be quite important when we're considering the adolescent, for example. So the causes are complex. It is genetics, epigenetics or environment in the womb, and environmental or metabolic. We've not been able to tease out substantive differences in genetics across the different world regions, and yet we know the manifestations of the condition do vary. It is not a simple monogenic condition. It's very much like other endocrine disorders, such as type 2 diabetes or even obesity. There's a multitude of genes available that increase risk. If you overlay that with epigenetics, and the epigenetics often with the in utero environment, especially with high androgens, and then the obesogenic environment we are increasingly moving into with less physical activity and increasing body weight, where we see all of those collide and an increase in the prevalence of this condition. The prevalence currently varies anywhere from around 10% up to quite high in some Indigenous populations, and we know throughout South Asia it also is a little higher than at the global level. Those factors then cause endocrine changes, and this is an endocrine condition, which are higher free androgens, hypothalamic and neuroendocrine disorders or dysfunction, and also higher insulin resistance. All of those hormone changes are exacerbated by increasing BMI. These lead to a myriad of reproductive features which extend well beyond the ovary. They include reproductive, such as oligoanovulation, a high prevalence of infertility, very significant pregnancy complications that are usually not recognised or prevented, and there is an increase in premenopausal endometrial cancer. Excess weight, we know that in this condition, women with PCOS and adolescents are more likely to gain weight, and that weight is more likely to cause and exacerbate the PCOS. So it appears bidirectional, and there's significant overlay in genetic, polygenetic background between obesity, metabolic disorders, and PCOS. There's a much higher rate of prediabetes, gestational diabetes, and type 2 diabetes at a much younger age and at a lower BMI. There's increased hypertension and dyslipidemia, and for the first time acknowledged in these guidelines, increased risk of cardiovascular disease. There's also significant dermatological implications, including hirsutism, hair loss, acne, and acanthosis, with acanthosis nigricans being a particularly problematic feature in people from South Asia. These factors lead to significant psychological impact, with anxiety and depressive symptoms occurring in 80% of women with this condition, poor body image and self-esteem, often disordered eating, and it has a greater impact on quality of life than diabetes. It's interesting and perhaps sad to reflect that self-harm is substantially increased, and recent data suggests that the suicide rate is up to 8 times higher in women affected by severe PCOS. This is a serious condition, and yet it's often been dismissed as simply increased facial hair or mild manifestations, which it definitely is not. And especially we think about vulnerable adolescents, they are often not getting their cycles like their peers and friends. They have increasing facial and body hair, which causes significant problems with body image. They have increased acne. They often get scalp hair loss, as I mentioned, and acanthosis. All of those things have significant psychological impact for adolescents. On top of that, if they are diagnosed, or once they're diagnosed, there are concerns about fertility and pregnancy, and we know they can have much broader psychological and social implications. So the diagnosis of this condition is really important for us to understand and apply consistently. Previously, the diagnosis were consensus-based, and each of the criteria were poorly defined. These transitioned from NIH to Rotterdam criteria to, in 2018, become the international guideline criteria. Those criteria have been tested, been shown to be more accurate, and limit over and under diagnosis. Not only were the criteria refined from Rotterdam, but they also had much more detailed defined diagnostic features. And more recently, we have added anti-Müllerian hormone, which can be used in the diagnosis. So Rotterdam consensus was the basis for this, but that's now grounded in evidence with the international guideline criteria. So in adults, this requires 2 of oligoanovulation, clinical, and if not present, biochemical hyperandrogenism, polycystic ovarian morphology on ultrasound, far preferably to be transvaginal ultrasound. If that's not appropriate, other avenues can be used. However, in that case, we would recommend using anti-Müllerian hormone levels instead. We do not recommend using both, it's one or the other, and exclusion of other etiologies. However, importantly, in the guideline, we recognise that this will overdiagnose the condition in adolescents, primarily because many of these features actually are part of the normal pubertal transition, and we need to make sure we are not overdiagnosing young women with this condition. So the adolescent criteria, which emerged with the guidelines in 2018, are oligoanovulation and clinical or biochemical hyperandrogenism with exclusion of other causes. Polycystic ovarian morphology and anti-Müllerian hormone levels are not recommended in the diagnosis in adolescents because they are simply not specific enough. So in terms of diagnosis, actually I'll just go back one moment and just mention where adolescents have one or the other of these, they are deemed at risk. It's very important that we don't simply dismiss the diagnosis in someone who only has oligoanovulation or only has clinical or biochemical hyperandrogenism, because up to 25% of these young women will actually have PCOS, and therefore we recommend at the age of 20 which is officially the WHO end of adolescence, that if they have one of these features, they are reassessed. So this is an example of how we've refined each one of those criteria for irregular cycles. That is normal to have irregular cycles in the first year post-menarche. For 1 to 3 years post-menarche, their cycles can be longer, so less than 21 or greater than 45-day cycles is said to be abnormal. Once they are 3 years post-menarche up until around perimenopause, it's less than 21 and greater than 35 days or less than 8 cycles per year. If they're post 1 year post-menarche and they then have a 90-day period without any cycles, or if they have primary amenorrhea by the age of 15, then all of these should trigger consideration of PCOS. When we're talking about PCOM, and I won't labour on this too much because this is not what we recommend in adolescents, but if we are using this, again, it should be a vaginal ultrasound where it is appropriate, and it should be based on follicle number per ovary. If, for example, we're talking about younger women who are not sexually active, then ideally we would be using an anti-malarial hormone and not an ultrasound after the age of 20. As I mentioned, AMH should not be used in adolescents, but if these young women and their adolescents are defined as at risk, so they have either oligoanovulation or hyperandrogenism, only one or the other, then by the time they get to 20 years old, they can go on to have an AMH, which is used to reflect polycystic ovarian morphology. It is not a single diagnostic test for the condition, and it should be used in the diagnostic algorithm, which I'll explain in a moment. So if we think about this in a more simple way, essentially what we have is for over 50% of women overall and for about 75% of adolescents, simply a clinical history and examination will be adequate to detect irregular cycles and clinical hyperandrogenism. Acne, yes, but in adolescents we know that acne is normal, so it does need to be more severe acne. For those who don't meet both of those, for those who meet both of those criteria, they have the diagnosis, and there are some tests I'll come to down the bottom that need to be done for exclusion. If they don't have both of those features, for example, if they don't have clear clinical hyperandrogenism, then free testosterone or free androgen index can be completed. Androstenedione and DHEAS are not recommended because they are less specific and have a tendency to overdiagnose. So if they have clinical irregular cycles and biochemical hyperandrogenism, then they have the diagnosis. Again, further tests are not required other than for exclusion. If they are an adolescent, if they're an adult, they go on to an ultrasound or an AMH level. However, we're talking about adolescents here, and we know that ultrasound and AMH is not indicated. So rather than just saying they've got one feature and that they don't have PCOS, we now very much say they've got one feature, hyperandrogenism or irregular cycles, and they are deemed to be at risk and get reassessed again at the age of 20. In terms of exclusionary tests, important to do a TSH, a prolactin, if they're from the appropriate genetic background, a 17-hydroxyprogesterone for non-classic congenital adrenal hyperplasia. For those women who are a little older, especially, an FSH level is appropriate. For other potential conditions, they are very much excluded based on the clinical features, and that includes hypothalamic or hypogonadotrophic hypogonadism for young women who are very lean and exercising significantly. So the other factor that was new in the guideline, and just to jump to this because we won't have time to go through all of it, was that for the first time, women with this condition should be considered at increased risk of cardiovascular disease and should be assessed for these risk factors. This includes starting in adolescence. The number of young women now who have cardiovascular or cardiometabolic risk factors in adolescence, including rising BMI, but especially including pre-diabetes and even type 2 diabetes, especially if they're from a South Asian background, is really quite concerning. So the way we tend to approach this metabolically is it's important to be respectful and not to be overly judgmental about the weight that we see in this condition. There is absolutely no question that increased body weight causes adverse outcomes in terms of health in this condition. There's no argument. It's the most potent determinant of fertility and response to fertility treatment, and it has significant impacts on pregnancy risks and on metabolic and psychological features. However, we do know that increasing BMI is not a choice or a failure of an individual. It largely occurs in our very obesogenic environment. For example, in Australia, we have around 70% of our population who are above the healthy weight range, and that is not a failure of personal lifestyle behaviour. So if we are talking about weight and stigma, and indeed I've just yesterday spent some time with some young women from a South Asian background who are in the UK, and the judgment and stigma they often described around the weight gain associated with this condition was quite distressing for them. So it's important as health professionals we don't add to that. Yes, we should inform them on the impact of weight on diabetes and heart disease and fertility, and highlight the opportunity for prevention, but making sure we are not overlaying too much guilt. And for example, if they're in a very unhealthy weight range, not expecting lifestyle alone will fix it. We are recommending an oral glucose tolerance test every 3 years or more often if they have other risk factors. Unfortunately, fasting glucose and HbA1c is just far less accurate. If that's the only thing that's available locally, it will be could be sufficient, but fasting glucose is better than HbA1c. In your particular population, the risks are very high, and we do recommend routine screening. Blood pressure, ideally annually. Lipids only really need to be done once at baseline, and they can be done subsequently from adolescence. This is subsequently if there are other cardiovascular risk factors. The main role of lifestyle in this condition from adolescence onwards is a really strong focus on healthy lifestyle for weight gain prevention. A bit like we would have healthy lifestyle and healthy diet for those who are diagnosed with diabetes young. With PCOS, we should be focusing on really healthy lifestyle and optimal weight maintenance, and at a minimum in terms of prevention. That's especially important for long-term fertility. Metformin prevents weight gain. We know it induces ovulation, it regulates cycles, and it also prevents diabetes, all of which are very relevant in the South Asian population. And whilst there is almost no data, and this is not a recommendation and a guideline, in my clinical practice with women from South Asia, we also often see a fairly remarkable response in the acanthosis with metformin. There are very few side effects with this medication. I'll talk a little bit about that shortly. There is also now a recommendation to consider medical and surgical therapy based on population guidelines where the BMI is particularly high, and that's because we know lifestyle alone is almost never effective for sustainability, and also highlights the importance of prevention. Really critical that this starts in adolescence. If we wait until they're in their 20s or later, that weight gain has already occurred, and we miss the opportunity for prevention, which is so much easier and so much more effective with lifestyle than once we wait till they're in the higher weight range. In terms of glucose, as I mentioned, really important in this condition that the 75-gram oral glucose tolerance test, where possible, is a better test. There is no point in measuring insulin resistance. Whilst it is very important in the condition, if a woman has walked 200 metres, sat down and had their blood test versus recently had a meal and then been waiting in the waiting room for some time, her insulin levels will be very, very different. So clinical insulin assays are of very little use. Yes, if you do a clamp study for 6 hours with 2 IV lines, you can assess insulin resistance, but we're not going to do that clinically. If a woman has PCOS, she is almost certainly going to be insulin resistant, and the two just come hand in hand. Very importantly, especially for the adolescent, is to recognise that this has very major psychological implications, not the least of which is often when it's dismissed by ourselves as clinicians. And we have data from around the world on this, that not only sometimes do we miss the diagnosis, but we often dismiss the features or just treat people at the time without giving them a diagnosis. And that makes the psychological features worse. They do have much higher depression and anxiety, as I mentioned, self-harm and suicide, a lot of social isolation because of those features we talked about, with body image, hirsutism, etc. If they are overweight, especially, they're more likely to have disordered eating and distorted body image. They may have challenges around psychosexual dysfunction, but they have quite significant impact on quality of life. And what we do know is if they are given a diagnosis and they do get evidence-based information, and they are coupled with a clinician who actually looks at all the features of the condition, that these are significantly ameliorated. We also know that if we treat the features, for example, laser, which can often be quite helpful for hair growth, as long as the skin color is not too dark or the hair is not too blonde, and in your case, that shouldn't be a problem. We know that treating that, for example, significantly increases mood and psychological features. But the plea here is not to ignore these. So the general principles are to recognise the psychological features are very common, and we must focus on what's most important to the young woman in front of us, to provide evidence-based information and treatment, and recognise that that will improve her quality of life. Screening, therefore, for these is highly recommended. The other thing is to know that it's really important that we do make that diagnosis early, focus on prevention and healthy lifestyle with our adolescents, because we know that body mass index is very profoundly impactful on fertility, on response to treatment, on clinical pregnancy, miscarriage and live birth rates. So it's really important that we have routine preconception care in these women and actually make sure that we've managed all of these things well and truly in the lead up to them seeking fertility. Very important also, because this is often missed, is that women with PCOS, no matter what age they have their pregnancy, have much higher risk pregnancies. And so PCOS status needs to be identified. In many parts of the world, especially in South Asia, when a woman marries, that's often heralding the fact that they are going to have a family. That's definitely not the case for example, in Australia, but I know it can be in many situations. So when we know that is happening, we should really focus on that preconception care. And then when these women do become pregnant, we've got a whole raft of complications, much higher risks that we need to focus on. This is still relevant in the adolescent because this gives us the opportunity for a reproductive life plan. We know that if we can have women planning their reproduction, if we can focus on prevention and we can optimize health, that they will have better outcomes. So what about lifestyle? I wish I could tell you that there's a magic diet or a magic bullet or a specific approach. There is none. What we do know is that a healthy lifestyle based on your national guidelines with fruit and vegetables and not much processed food and limiting fat intake and sugar intake is very effective in PCOS. But there is no one miracle diet. And one of the problems is there's a lot of misinformation on social media, which often implies there is miracle cure diets. Everyone seems to know how to advise these young women, especially who are vulnerable, that they should do this or should do that. And yet there is no one special answer. But it's important we don't, when we're giving lifestyle advice, simply say nothing works. It does work, but it's what works for them and how we construct that to be tailored to them and still based on healthy lifestyle principles. The critical role of lifestyle is in prevention from adolescence onwards, because we know adolescence is a time of rapid weight gain in this condition. So lifestyle is really important and first up. Once we've moved past lifestyle, and just to highlight that exercise or physical activity, which I know is often difficult when we come to medical therapy, we should be targeting whatever the young adolescent and her family's concerns are. And they may be acne, it may be hirsutism, it may be future concerns about fertility, it may be cycles, it may be all of those. But it's really important we ascertain what they are. All too often, the feature that's treated depends on the doctor a woman sees. If she sees a gynecologist versus an endocrinologist versus a dermatologist, often she has a different focus of treatment, and we need all to be concerned about these more broad features. We do need to be empathetic and consider the impact on quality of life. In terms of medical therapy, and we almost certainly need to reframe this away from the combined oral contraceptive pill, because in this condition, it's not being used for contraception, it's being used for hormonal therapy. So if we frame the combined oral contraceptive pill as hormonal therapy in PCOS, it is very effective. And I know there are often implications or concerns about acceptance with the use of these medications, which is one of the reasons that as we're moving to try and get them approved specifically for PCOS, we're looking at framing them as hormonal therapy rather than as contraceptive therapy. I'll talk a little bit about these shortly. Metformin, very effective, especially in the more insulin-resistant versions of the condition. And anti-androgens, there is relatively little evidence for, and we tend to use those more for people who have hair loss. However, some evidence on anti-obesity agents, I'll mention that, and also inositol. Just to note, throughout most of the world, these medications are not indicated for treatment of PCOS, and they're actually prescribed off-label. So off-label use is possible, but it's not actually approved for use, and it's really important that we don't rest on our laurels there and actually make sure that we're advocating for use of these medications or for approval. Indeed, India has now approved metformin for the purpose of treating this condition, whereas other countries around the world are only just starting to catch up. So in terms of the combined oral contraceptive pill medical treatment, the mechanism is important. It is hepatic and it increases the sex hormone binding globulin. So this is not about the type of progesterone or the dose of estrogen. It's actually about the fact that it is taken orally, it goes through the liver, and in that context has an impact on the binding proteins, which significantly reduces free androgens. Other forms of contraception will not do that, and so it does need to be in this format. In terms of the types of contraindications, these are fairly standardized, and we do need to consider the fact that there are high metabolic risks. We recommend low-dose natural estrogens, and we don't recommend using the higher dose combinations. They should be used for at least 6 months at a minimum for hirsutism, and really we should not be using anti-androgens until we've had at least that time. Where you know the hirsutism is distressing or severe, and where you can access it and where the skin color is not too dark, laser can also be very effective. And indeed, these guidelines for the first time have shown a significant improvement in hirsutism and a significant improvement of psychological features. And the combination of the pill and the laser is very effective. Only if they're ineffective after 6 months should anti-androgens be added. And if you are using anti-androgens, be very, very careful that these young women do not subsequently become pregnant, because they can have an adverse effect on the virilization of a male fetus. In terms of metformin, this has been around for 100 years. It was originally derived from lavender. I like to tell that to my patients because it emphasizes that it had a natural derivation. We recommend it should be considered for BMI greater than 25, and that's for weight gain prevention, metabolic outcomes, insulin resistance, glucose and lipids, and in your population also for acanthosis. And for those who are under BMI of 25, and indeed in the South Asian population, less than 23 is probably more accurate, or in adolescents it can be considered. In adolescents there is less evidence. It's not that there is not, beg your pardon, it's not that there is evidence it is less effective. There is just less studies and less evidence, but definitely it can be considered. It does cause ovulation induction, but it takes 6 to 12 months to work. It can regulate cycles. It is a safe and effective treatment for infertility, but it's important to know, whilst it's safe, low cost, it is also lower efficacy than other agents. So if you have a young woman, and I know we're not talking about fertility so much here because we're focusing on adolescents, but if you do have a younger woman who's planned her pregnancies earlier, metformin has longer to work before you need to use other agents if you're starting early. In our context, we often see women coming into fertility later, and then we don't have enough time to use metformin and we have to move to stronger therapies. We do start at a lower dose and increment, and we do tend to use the long-acting agents. And as we all know, with metformin, there are some mild, self-limiting gastrointestinal side effects, which are usually dose-related. And if they occur, we simply come back down to the dose that they tolerate. I won't go into it in great detail, but inositol has been very heavily promoted, including on social media. We often see use in adolescents. Inositol biochemically makes sense in terms of the way that it works in the body on insulin resistance, but so far only biochemical impacts have been demonstrated, does not change the clinical features of the condition, and indeed it's proven to be inferior to metformin. So in this context, right from adolescence, we emphasize the importance of early diagnosis, prompt information provision, which I'll talk to shortly, and a long-term health and reproductive life plan, which has a really positive message around it, including planning for pregnancy. Women who are going to try to conceive younger, and I know that's more likely to be the case in South Asia, women who have a lower BMI are much more likely to be able to conceive even if they have PCOS. And therefore, where possible, and I don't mean it too early, but where possible, earlier family initiation is advised. That critical message about healthy lifestyle and trying to weigh young women to keep them in the healthiest they can be, no matter what the starting point, to get that lifestyle as healthy as we can. Screening and monitoring those cardiovascular risk factors, especially including for diabetes. As I mentioned, many of these young women actually have dysglycemia or type 2 diabetes even in adolescence. And metformin is very appropriate to consider on infertility at all, because it's really an area we treat in adolescents. But I will highlight that we know that we can optimize fertility again if we can work on prevention of weight gain, if we can optimize lifestyle, if we can get the diagnosis made early, and if we can make sure that women are not starting their family too late. And in this context, there's a fairly simple algorithm whereby most women with this condition can either have metformin, which you can see on the left there in the purple, sorry, on the right there in purple, or letrozole. And that is all most women will require. IVF is not specifically indicated in this condition. And the reason this is important to note is many young adolescents and their parents and family, when they have a diagnosis, are often quite devastated about the potential impact of this condition. And it's really important that we make sure that we can tell them that most of them will go on to have a family, especially if we can keep them healthy in the interim, and that they may need a little bit of assistance, for example, medication, but very few of them will need costly or more extensive therapy. Really importantly for adolescents, especially where information needs are critical, there's a whole range of resources that are available on freely on the website, and indeed they're in multiple languages. And the app, which is on Google Play and App Store, Ask PCOS, has all of the information from the guidelines in the format of answering the 95 top questions that women and adolescents had. It does have resources on there on many different languages, but essentially it provides them with evidence-based information and does not try to sell them anything, does not mislead them in terms of diet, emphasizes that long-term their fertility outcomes are likely to be very positive. So really important that they have appropriate information. And because this condition is so complex, it's very hard for a clinician to be able to provide them with everything. Therefore, that makes it really critically important that they get that information from a reliable source. This app is currently used in 195 countries and is well over that 53,000 users now. So I just would commend you to have a look at the guideline and indeed to have a look at the resources which you are freely able to use. And thank Chandrika for her involvement in the guideline. Thank you very much.
Thank you, Professor P. I think there's a few questions for you. Yes. This question on prolactin, that polycystic ovaries and prolactin, at which level we should allow this treatment for other prolactin causes.
So I'm having just a little bit of trouble hearing the question. Could I ask you to speak up just a little bit? I'm having trouble hearing the question. Sorry.
Yeah. In some PCOS, prolactin is elevated. At which level we should be allowed to investigate for the prolactin secreting causes?
Prolactin levels.
Yeah,
okay,
yes.
Yeah. So there is not evidence that women with PCOS have higher prolactin. And the reason for that, the reason it came previously, that suggested previously that they have higher prolactin, is because often in the large cohorts of women that were recruited, or adolescents even that were recruited for study, there were women in there who actually had hyperprolactinemia, and they were not excluded. And then when you average the level, they looked higher. But in fact, if you actually don't do that, and we've now got a very large integrated cohort of 15 different studies, including many women from your part of the world, and the prolactin level is not any higher in PCOS than it is in women without PCOS, if you exclude those who actually have hyperprolactinemia.
You said it is advisable to the OGTT in adolescent also every 3 years, right? So how often we screen for other cardiovascular risk factors?
So the OGTT should be a minimum of 3 yearly. But if you've got someone who's got, for example, a family history, increased BMI, had a fairly high basal level last time, you may do it more frequently. For the other cardiovascular risk factors, it's yearly for BMI and blood pressure. Lipids do not need to be done on a regular basis in younger women, especially. They just need to be done at least once. So most of it is annually, the OGTT between 1 to 3 yearly, and lipids is just a one-off. I can also see there's a question about changing the name of the condition, if I can just briefly address that. So yes, we do need to change the name. First of all, they're not cysts, they're not epithelial lined, they're follicles. Secondly, it is really misleading to suggest it's an ovarian-only disease. It is, in fact, as we know, a reproductive and a metabolic condition based on the genetics. We have tried several times over the last decade to get a consensus around the fact that we need to change the name globally. We finally achieved that, and so at a recent, we've actually got surveys now from around 8,000 healthcare providers and women around the world, including many from South Asia, where we've looked at, we've also explored a whole range of what their names may be. But more recently, we took that to an international workshop, and it was agreed, there was a consensus that we should change the name, that it will progress, and that we have a process that's agreed to do that. What I can't tell you is what the name will be, because that does need significant input from patient groups and also very significant engagement from throughout the world. And at the moment, we have a lot from the UK, from Europe, from Australia, from the US. We do not yet have enough engagement from Asia generally, and also from South America. So those two world regions are a focus at the moment. And once we've done that, we will be having a series of specific strategies to come to what the best name may be. But at the moment, the suggestions have either been reproductive metabolic syndrome, or indeed keeping the PCOS, but possibly to be polyendocrine, cardiometabolic, ovulatory syndrome. And so that's the two most common proposals on the table at the moment. And so it'll be watch this space.
There are two more questions. The first question is, does the PCOS have any effect on breast development?
Look, interesting question. I've got a PhD student working on that at the moment. There's not much evidence that it does, but what we do know is that higher BMI, which we see in these young women, so obesity per se, does significantly impact on the ability to breastfeed. And it's probably more the BMI than it is PCOS. We've looked at a whole range of different endpoints, and indeed looked at the literature in many different ways. So yes, these women have lower rates of breastfeeding, but it does appear to be primarily BMI related, and doesn't seem to affect breast development per se.
Is the sleep apnea depend on the obesity with the BMI, or is it common with all polycystic?
So you mean the breastfeeding challenges?
No, sleep apnea. I'm asking the sleep apnea. Is it depend on the obesity?
So, I'm sorry, there's just a little bit of problem with the static at this end. I'm not quite hearing the question.
Yes. What about the sleep apnea? Is it common with the obesity?
Oh, sleep apnea, I beg your pardon. Yes. So sleep apnea is independently increased in PCOS. independent of obesity, and it is significantly higher. And then with obesity overlaid, it's significantly higher again. So I haven't mentioned it here in the time that we had, because I didn't have time to cover it all, but sleep apnea is much further increased. But one of the things we know is that treating sleep apnea doesn't improve the metabolic profile in these women. So you would only treat sleep apnea if it clinically causes symptoms. And so we recommend screening based on fatigue and the symptoms of sleep apnea. And if they have that, then you go on to screen it. But yes, it is significantly increased in PCOS. I can also see there's one there on the best station for ovulation induction in someone with PCOS. So I hope to cover that in the preferred age by far is young women who have helpful, but there's a very large trial in the UK underway at the moment. And then basically, if letrozole does not work, meaning if they don't ovulate at all on letrozole, they could add or potentially IVF. But if they ovulate and they don't see, they could go on to gonadotrophins, and it ultimately to IVF. For most women, letrozole.
I think there's a problem with your internet connection.
She missed the connectivity, sir.
Sorry?
Madam missed the connectivity, so she disconnected.
Yeah, okay, there's a problem with
She's joining now again.
Sorry?
Madam is joining now again. She's there.
Yes, my apologies. For some reason, the internet dropped out. I hope you can hear me now.
There are two more
Yes,
questions.
and there's another. I can see there's a question in there a bit more about AMH.
Yes.
Yes, yeah, I can see that. So in terms of AMH to diagnose PCOS, so in adolescents, no, as we mentioned. In adult women over the age of 20, we can use AMH instead of ultrasound. The cutoff depends on your laboratory, because there are different assays and different, I can't give a number you would buy, but within the next 12 to 18 months, we should have absolute cutoffs for top 3 assays. Though we say rely on what your laboratory gives you as a predict fertility, we just use it to make the diagnosis for the condition. In terms of the relationship with PCOS and pelvic infection, no, there is no relationship between the two at all. That's been proven. And the recommendations to reduce the risk of preterm labour. So metformin does reduce preterm labour risk, and it also does so in PCOS. I haven't shown you the recommendations for metformin in pregnancy here because we were focusing on adolescents. But if we go back to their risks in pregnancy, these women are often higher BMI. They have much more gestational diabetes. So we would be expecting them to have much bigger babies, but they don't. They actually have small babies, and they have small babies because they have placental insufficiency, because this is a metabolic and vascular condition. And in that context, there is some concern about whether metformin may be a problem in that context of pregnancy. There doesn't appear to be any adverse effect during pregnancy. There may be offspring effects up to 8 or 9 years later, because often the offspring may have slightly higher obesity. However, it does reduce gestational weight gain, and it does reduce preterm labour. So the recommendations generally are that metformin may be appropriate in a woman who's got a higher risk of preterm labour, for example, if she's had a previous preterm labour. And at the moment, we have brought together all of the studies that have been done around the world, the randomised controlled trials of metformin in pregnancy and PCOS. And we're actually analysing that data at the moment. So we have the original data from the studies and should be able to define exactly what the role of metformin is in pregnancy in this condition.
So thank you very much, Professor P, for that wonderful lecture. Probably we might give some questions at the end of the other two lectures. So thank you very much for spending your valuable time with us and enlightening on important topics like that.
Thank you very much. I'll leave you there. Bye-bye.
So it's my pleasure to introduce the next speaker, Professor Chandrika Vijayaratna. She's a senior professor in reproductive medicine, Department of Obstetrics and Gynecology, Faculty of Medicine, University of Colombo. And she's an honorary consultant physician in the Women's Research Hospital for Women and National Hospital, Colombo, Sri Lanka. She received the Laureate Awards in 2017 for International Excellence in Endocrinology, awarded by the Independent Society USA in its interview year. Her main research on hyperglycemic pregnancy, polycystic ovary, pregnancy resistance, and she had a lot of research and theory articles on polycystic ovary disease and diabetes. And she's a former vice chancellor in the University of Colombo, Sri Lanka, and past president of Sri Lanka Medical Association, and past president of Sri Lanka College of Physicians, and she's a past president of Independent Society of Sri Lanka. Thank you, Madam, for accepting our invitation. It's over to you.
Thank you very much. I hope I am seen and also my slides can be seen, I hope. So at the outset, can I,
No, Madam, you have to share the slide.
oh dear. I have to share the slide. Now, can you see it?
Yes.
Yes, Madam.
Right. So may I at the outset thank the president and the chairperson of the academic program from the Sri Lanka College of Obstetricians, both with whom I have had the pleasure of working over the past couple of years. And I think we can recall wonderful memories of teamwork and multidisciplinary care. So in this context, I was given a hard task of addressing the post-reproductive woman and by Dr. Darshana. And so having listened to that very wide-angled, evidence-based lecture from Professor Helena, I think it made my task easy, but at the same time a bit difficult because there's less evidence about these women. So I would just like to recall and advise my colleagues, both from endocrinology and from obs and gynae, that this being a life cycle presence of polycystic ovary syndrome, as it's called now, with the metabolic issues, I think we need to do longitudinal studies in our part of the world, which can give out a lot of information. So I think that is something I would like to recommend to both the two colleges. Can I move the slide? Yes. So as Professor Helena said, commonest endocrinopathy in young women. So if we take our population, it's about, say, if it's 10% of the young women, it would be anything in a couple of hundreds of thousands of women. In addition, the fact that it affects the psychosocial aspects has to be retained in our mind, even in the post-menopausal woman. So let me delve into the pathophysiology, because sometimes a good understanding of the pathophysiology helps you in addressing most of these issues that were mentioned and which we will also discuss, as much as the South Asian perspectives of the metabolic syndrome, as Prof. Helena was referring to, since we are the hotspot, the epicenter of diabetes in the world, Atlas. So let us get to the menopausal transition after getting over those two first points, and also to work on how we can give a holistic care. So this was depicted in the previous by the previous speaker, but I would like to say that there is no unique feature to this condition, and therefore we need to appreciate that it's a heterogeneous presentation and that we cannot dismiss the symptoms, as she quite rightly said, of oligoamenorrhea or hyperandrogenism, which may be clinical or biochemical. When it comes to the ovarian ultrasound, I think many of our radiologists do in the adult woman and in the older woman support us. But as mentioned, if it has been done once, there's no purpose going on scanning. One word about hirsutism. Our background, we can actually quantify hirsutism by Ferryman-Galway score. There are ethnic variations. There are some communities, even in our country, who are more hairy as a background situation. So you need to be appreciative, but always please listen to the patient, because whatever our count is, even a very low score might so terribly affect the psychosocial aspect of the women. Alopecia, in as much as it can be androgen mediated, just remember that iron deficiency can also be a cause, and please try to correct that in such a situation. When it comes to acne, it was mentioned, it is physiological and it occurs more in young than older women, and I shall also share with you some of our own data. So when we look at the pathophysiology, you can see that the ovary is the main producer of androgens, and that is induced by insulin, which is produced in larger quantities from the beta cell mass due to the peripheral skeletal muscle and adipose tissue induced insulin resistance. It's a selective insulin resistance that these women are affected by. Ovaries are not insulin resistant, and therefore the insulin will act on the insulin receptors of the ovary, which help to produce theca cell, via the theca cells, androgens. Undoubtedly, through the FSH-LH pathway from the pituitary, LH-driven theca cells also will produce androgens. Now, what I would also like to say that undoubtedly adrenal can be a contribution, but this is primarily an ovarian induced. So when the ovary becomes smaller in and around menopause, undoubtedly the androgens are expected to come down. But on the other hand, even I can also share with you that in our local laboratories, most of the women would have the androgen values within the normal range, but in the upper quartile. But the free androgen index, which we don't measure, and I wouldn't recommend you to measure, is insulin determined through the liver, where it will decrease the sex hormone binding globulin. Therefore, the free available androgens remain high, even though the total androgens may not be strikingly high. So the androgen bioavailability, as well as the issue about the skin sensitivity, hair follicle sensitivity to the androgens, needs to be borne in mind. As I mentioned, the androgen excess would also bring about high estrogen, and that is through the peripheral pathway through increased aromatization. So the high estrogens make the endometrium thicker in these women, particularly if they are not put on the pill and do not have regular periods, provided they are euthyroid. And therefore, in and around the menopause, we need to be conscious of endometrial polyps and endometrial hyperplasia causing dysfunctional uterine bleeding, and it is mandatory, more or less, to exclude a possible endometrial cancer by the appropriate histological examinations. So just to recap, it's a hypothalamically driven, pituitary-driven ovary, the theca cells producing androgens, further enhanced by the insulin, but the androgens actually increase the adipose tissue. Therefore, it's like a vicious cycle. So you can appreciate that endometrial hyperplasia is one risk that these perimenopausal women can have, abnormal lipid profiles through the androgen pathway as much, which means, as mentioned earlier by Professor Helena, we need to do the metabolic assessments on a regular basis in our high-risk populations, but not resort to the very expensive tests of fasting insulins and SHBG. As was mentioned earlier, in the early phase, when you are diagnosing, you need to do FSH-LH, and only if necessary, the AMH in a later woman, particularly related to fertility. But a thyroid function test, I would like to emphasize that in our populations, about nearly 5% of women of reproductive age can have subclinical hypothyroidism, and particularly if they are going in for preconceptional assessment or having dysfunctional uterine bleeding, to please remember to do a TSH. There was a question about prolactin being high. Undoubtedly, through the LH pathway, prolactins can be marginally high, but usually if it is more than one standard deviation, and that they are not taking medications that can produce high prolactin, particularly anti-anxiety, antidepressants, which the patient may not tell us about. So we have to ask some leading questions, and always to examine, to test the prolactin in a very standardized manner. I would say it should be preferably in the early phase of the cycle in a woman who's menstruating, as well as to time it around midday with a cannula or a butterfly needle placed in for at least 15 minutes for the second sampling. So if you get one sample that is high and the other causes are excluded, then I would suggest you repeat the prolactin where the patient has been without eating or drinking for at least 4 hours. Remember, cool drinks, ice drinks, which we are drinking these days, can increase a woman's prolactin. So fundamental principles have to be followed, and you need to standardize your measurement of prolactin, particularly the obtaining of the sample. Another word is that I would like to emphasize that these women are eugonadotrophic. Undoubtedly, LH could be more than FSH, but remember, if a woman has not been tested and she is unmedicated, please check the FSH and if necessary, the LH, to make sure that they fall into this category and not hypogonadotrophic category. The other causes, as we said, should be meticulously looked for both clinically and biochemically, and we need to keep in mind the metabolic syndrome and the impaired glucose tolerance component through a GTT, which needs to be followed up well into the menopause. So just to recap, the caring doctors have to face a certain amount of challenges. It's a complex condition. You need to individualize. There can be economic problems, particularly in today's day and age, where out-of-pocket expenditure is more or less unheard of unless the patient has enough cover. And also to keep in mind the rising burden of obesity, which is really more amongst the lower socioeconomic groups due to increased starch intake. As mentioned by Professor Helena, the long delays in diagnosis should be given due attention to, and avoid the patient complaining of poor diagnosis experience as much as they need to be supported, particularly from their perspective of emotional well-being, and not being marginalized or stigmatized, particularly when it comes to marriage. So what about the metabolic syndrome, which is more common in our area? I mentioned this approach to the insulin resistance, developing more and more adipose tissue in as much as high androgens. We need to break this vicious cycle by lifestyle as well as metformin. But we need to appreciate that the sympathetic nerve activity is also increased in these conditions. It's not just through anxiety, and they can also have inflammatory markers, which need to be borne in mind for the perimenopausal and the older woman. So if you look at the younger women that we collated about 469 women with complete data from our clinic experience at the De Soysa Special Clinic, one could appreciate that there was the classical well-characterized in about 60% of these relatively young women, while there was about 20% of them belonged to the lean PCOS who had regular cycles but were severely hirsute. And those are a challenging group of people. And when it comes to the perimenopause, because of their relative slimness, we might overlook the fact that they have the metabolic syndrome. And when we look at whatever the diagnostic criteria for metabolic syndrome, be it the National Cholesterol Program or the IDF criteria, you can see even in the slim PCOS, they were neck and neck, and indeed occurring in about a third of the patients. Acanthosis nigricans often cannot be missed. in our patients, but when you see it, please take note of it, particularly to my obstetric colleagues, because lots of pregnant women would anyway have it, and we wouldn't really take it as seriously. So be it the younger woman or the older woman post-reproductive, if they do have these features, rather than measuring the insulin, we know that if their BMI is high, that they qualify for metformin, because the women are extremely perturbed by this condition. The younger women's mothers are also concerned about it, and therefore we need to help them. In fact, our data of our 469 patients, which we reported in 2011, I believe, it was very clear that they had, some of them had even on their faces, which we were not, we were probably the first to report such, and it obviously is a racial feature. And although this is not a diagnostic criterion, so please pay heed to it. And the fact that obesity, the cutoff being 25, but the lower the better, that metabolic syndrome, when it is there, the impaired glucose tolerance can occur in as much as 39% versus the PCOS without the clear metabolic syndrome being a bit less, but 6 times greater prevalence of type 2 diabetes in this young population. So you would appreciate that as we grow older, our risks of diabetes become higher, and I will show you the population data, but undoubtedly these high-risk groups, you need to be very conscious of the presence of diabetes and cardiovascular risks. So you would ask, is it genetic? Well, we did the FTO gene polymorphism screening by a very comprehensive genetic assessment of about 100 women by Dr. Umayal Branavan, who works in the faculty, and she found that the FTO gene polymorphism is in favor of obesity and metabolic syndrome. So undoubtedly, there is a genetic basis, but also there are fetal programming basis, but particularly environmental issues. So we cannot blame the women. Please do not encourage any form of stigma, and give them the correct support throughout their life cycle. So as to the indigenous populations, when I did my thesis way back in at the turn of the millennium, we found that the women residing in the UK of South Asian origin, who were particularly of Pakistani origin, were younger when they manifested symptoms, and they were more hirsute, and they had a higher prevalence of diabetes. And of course, for research purposes, we measured the insulin and the HOMA. And while in our clinics, we found that even though at the age of around 25, 26, about half of them or more were unmarried and not planning pregnancy, that they had a fair share of issues about oligoamenorrhea and hirsutism. And therefore, we need to give them total care, particularly when they're coming in for treatment for infertility. And this also is a pie diagram just to show the distribution of the different subphenotypes, which are not really necessary by the current guideline, but we tend to realize that those with all 3 features tend to be more severe. Now, Dr. Vindhya Kumarapalli carried out community prevalence, which was one of the best community prevalence studies in the world. And you could appreciate that these were young women, less than 40, and they had a prevalence of around 6.3%. This is in the community, mind you, whereas our clinics are overburdened. But the metabolic syndrome affected these women as much as 1 in 3. So when we go to the next slide, and one important aspect is nearly half of them did not seek treatment. And I think this is again related to the socio-cultural issues, and we need to be conscious of this. So when it comes to population weights, is PCOS linked to weight gain? And undoubtedly, yes, if our populations tend to gain weight, PCOS will also manifest more. And what about our region? In fact, the world data on global health shows that our countries are the ones that have gained the most amount of weight. This has multiple reasons. This is not the forum to talk about it, but it is interesting. We went through a lot of foreign rule and subjugation, famines, and therefore we developed the thrifty phenotype and the thrifty genotype, which made our higher risk of developing the metabolic syndrome. So, overweight and obesity, central obesity, we need to measure the waist circumference if necessary, and need to appreciate, that each unit of the BMI rising increases the risk of polycystic ovary syndrome by much as 9%. So going back to Dr. Mindya's data, you would appreciate that dysglycemia, be it pre-diabetes or diabetes, affected 1 in 5 women in their 20s. And the odds ratio was 2.3. So we need to appreciate that this can affect the quality of life and well-being. And particularly what we found was that the hirsutism affected them even more than the obesity. So let us look at the latest diabetic data from the Ranan-Elia group. And you would appreciate that the hot spots are Colombo and Jaffna, although there are very dark orange spots in Gampaha, Mana, and Trincomalee, but it's more or less prevalent, highly prevalent in the majority except in Monaragala and Matale districts. But there is a female preponderance. The older they get, there are greater women. I'm not saying these are all PCOS, but we need to keep this in mind. You can see that with aging, the women's prevalence keeps rising in terms of diabetes and in as much as higher the BMI. So it's a lifelong condition. At the study group held in Rotterdam in exactly 12 years ago, before Helena and her group started the international guidelines, this was the cartoon that was developed, that the metabolic disease is what needs attention in the older woman. But now we have changed due to the fact that the earlier you start plugging the problematic areas and addressing metabolic disease, the less chances of cardiovascular disease. And of course, we need to keep in mind that they have to have regular periods and ideally avoid endometrial hyperplasia and increased cancer risks. So what about the natural history in the perimenopause and postmenopause? You would appreciate we saw women who were probably in their mid-20s predominantly at the turn of the millennium, and reported and evidence-based guidelines have been developed over time on those women. But those same women must be about closer to the menopause now. And this is, I believe, an opportune moment for Sri Lanka to also address the aging woman. And we need to appreciate that women with the PCOS tend to have more regular cycles when they go beyond the age of about 40, simply because there's a reduction in the ovarian volume size and the number of follicles. So although we would, at the end outcome, say endometrial cancer clinic or in the cardiovascular clinic, if we try to work out, has this woman had PCOS, please bear this in mind that the older woman would report that her periods are regular. And you need to ask her to recall way back to her younger days in her 20s and 30s. As to the menopause, it is reported to occur a couple of years later. As we all know, the heavier the woman, the menopause is later. So the mean age of menopause for Sri Lanka and much of the world is about 51.3. And so I would believe it's closer to 55 in this group. There is a decline in androgens because of the reduction in the follicular size, and the periods are regular. And maybe endometrial thickening is not as common, but we need to appreciate that the risk is there. It is also interesting that the period pattern is unclear in the perimenopausal woman. And in terms of hot flushes, it may be due to the higher estrogens. They have been deemed to have been reported less, but these are things we need to really address on a unbiased sample of matched samples or RCTs. When it comes to the postmenopausal woman with PCOS, please remember the hirsutism might remain a problem for her. So we need to address them as clinicians, as well as we need to be appreciative of the cardiovascular risks, although there is no substantiative data from the most parts of the world where they have recorded it, and that happens to be in Northern Europe. So this is a collation, this is a busy slide. I'll be sharing it with you through the organizers, but you would appreciate Czechoslovakia, Sweden, US, UK, the Netherlands, Finland, and back again the UK that did longitudinal follow-up because it's a very challenging method, and that is PCOS and controls. And you could appreciate that diabetes and hypertension seem to be higher, but as to the cardiovascular events and total mortality rate has not been reported to be high. So this is something we need to address because we have the problem of aging women. Endometrial cancers have been reported to be higher in the PCOS group in the postmenopausal woman. And this was by Sarah Wild, who did a 31-year. So at the time that I learned, like you all, about PCOS when we didn't know much, Sarah Wild, who's an epidemiologist, started having a long-term follow-up of a large group of women. So to summarize the metabolic and cardiovascular issues of peri and postmenopausal women, we need to appreciate that type 2 diabetes in the postmenopausal woman coming out earlier at that point is not significantly higher. It is undoubtedly high, but there is a background population risk as well. So you need to appreciate that we cannot blame the PCOS by itself. It's linked to a high BMI, and we need to appreciate that what has been reported on diabetes in the postmenopausal women, those have very high triglycerides. So please remember to pay attention and refer appropriately for those situations. Blood pressure needs checking at every clinic visit or encounter, definitely beyond the age of mid-30s. And the metabolic syndrome should be addressed as well, as I mentioned, by simple measures of waist circumference and blood pressure, lipids, and blood sugar, ideally OGTT. I must also say that a Sri Lankan group led by Professor Nirandra Kumar, who's in Birmingham, and Dr. Kumarendran, have done a large data set assessment and have published it in a very reputed journal, where the risk of obstructive sleep apnea is definitely about 20% higher in women with PCOS. And that is thought to be linked to androgens, because men generally have more OSA than women and more than the BMI. Mood disorders is something that we need to address with our particularly psychological colleagues. And I must say that Dr. Achini Ranasinghe, a psychologist, did and has reported about all the issues of mental health problems when it comes to PCOS in a Sri Lankan cohort. And it's worthwhile you're glancing through her publications. As to the endometrial cancer risks, are they attenuated after the menopause? I have been reading around it within the last couple of days, and it has been reported that they are totally clear well beyond the age of 65, and therefore, from a gynecological perspective, I think we need to keep that in mind. So we need, I repeat, large-scale community-based follow-up data studies, and that is, to summarize, they tend to menopause a bit later, they have greater mood disorders, they have more metabolic risks, and we need to be conscious of coronary artery and cerebrovascular risks and outcomes, and endometrial cancer. We hope that we can mitigate it. So this is a lifelong condition. Professor Helena also addressed this. The primary care doctor plays the greatest role, which would be the first contact for many of these, and undoubtedly we who belong to the different fields would play a role. One issue about androgens being used for to control the hirsutism, please note that it should be combined with the pill, otherwise they get irregular bleeding. So I think I'll stop there, Dr. Mangala. I can leave the slides because much of what I have said has been addressed by Professor Helena. I hope that is okay, since time is running out.
Thank you, Madam. That interesting. So there are two questions. This, we have seen a lot of patients now with hirsutism after menopause, and few patients had hyperpituosis. How do you treat that after the menopause comes with hirsutism?
I'm sorry, I have missed that.
Yeah, we have seen, Madam, several patients coming with hirsutism
Yeah,
after menopause.
after the
Few
menopause,
patients, yes, and some of them had hyperpituosis.
right.
Most of them had polycystic
Yeah.
ovary. So how do you treat this case?
Yeah, I think that's a very good question. To be very honest, I don't know how common hypertrichosis is in a non-PCOS woman, so we need to be appreciative of that. But if a woman comes with gross hirsutism, and particularly maybe clitoromegaly, we need to measure the testosterone and the FSH and LH. And that would help us to diagnose hypertrichosis. And on the balance of probabilities, in such situations, I would recommend that you all go in for surgical intervention and biopsy. Basically, excision and biopsy.
Can you use spironolactone for a longer period? Is it safe in menopause?
Well, yeah, in a postmenopausal woman, spironolactone, anyway, remember the cardiologists use it in smaller doses, but we need to be conscious of the multimorbidities in the older woman. And therefore, finasteride may be a better option, provided that the liver is not affected too much. You need to monitor the liver functions. But spironolactone alone would be helpful for the postmenopausal woman. But in the younger woman, I would like to re-emphasize, if we use it, we need to combine it with the pill. Otherwise, they get irregular bleeding and creates a lot of problems for the woman. And also the fact that we need to maybe give a drug holiday from time to time, but I would still leave it to the patient to decide. And therefore, we need to have a combined decision making.
So what is the place of anti-obesity drugs, Madam? Study used
Yeah.
the combination of
Actually,
metformin?
Yeah, actually, on my slides, I had addressed that. So metformin is not going to reduce weight. It is really lifestyle modification that will reduce weight. What metformin does is corrects the insulin resistance and also prevents somebody going further into insulin resistant state and develop frank diabetes. From a perspective of liraglutide and others, those would be very useful, provided the cost factor can be overcome. But I would still say that bariatric surgery, which probably is cheaper in the long term, is what should be recommended for the older woman who is really facing a problem with her weight initiated from young days due to PCOS.
Thank you, Madam. Since we are behind schedule, we move to
Yes.
the next lecture.
Yes. Thank you very much.
Thank you, Madam. It's my pleasure to invite the next speaker, Dr. Udar Jawardena. Udar is BBS and MD in obstetrics and gynecology, and he has a fellowship in reproductive medicine IVF at Cambridge University Hospital in UK. He is currently working as a consultant in software degree at the Colombo North Teaching Hospital, London, and he is assistant secretary of the Iran College of Obstetrician and Gynecology. So he's going to talk on PCOS from infertility to pregnancy. It's over to you, Udar.
Thank you very much, sir. And thank you very much for the kind introduction. And also, I would like to thank you as the president of SLCOG and also Dr. Darshana as the chairman of the scientific committee for giving me this opportunity. So I'm going to basically talk about the infertility aspect of polycystic ovarian syndrome. Of course, I think by now, the two previous lectures very comprehensively covered the epidemiology as well as the pathophysiology and almost every aspect of PCOS. So I will quickly go through the initial slides and move on to the infertility strategies for these women. So, obviously we know that it is the commonest endocrinopathy involving the women in the reproductive age group, affecting about 10% of women globally. But also there is higher incidence in our part of the world, especially in the Southeast Asian region, as well as in the Eastern Mediterranean regions. And also there is wide variation in ethnic expression of polycystic ovarian syndrome. And so when it comes to infertility, we know that about 1/3 of women who are coming for fertility treatment are having the problem of anovulation. And most of these women, about 90 to 95% of women, are known to have polycystic ovarian syndrome. So it affects adversely by infrequent ovulation or anovulation, by reducing the quality of the oocytes, due to insulin resistance leading to hyperinsulinemia. And also there are effects on the endometrium as well, resulting in increased risk of miscarriage. So I think Madam covered most of these things. We know in PCOS, they have high levels of luteinizing hormone, and the LH-FSH ratio seems to be high. And these changes leads to overproduction of androgens, and also leads to the macroscopic changes that we see in the ovaries, like arrested maturation of the follicles. Okay. So in addition to that, I'm not going to focus in this area, but I will just mention when the women get pregnant and they're known to have polycystic ovaries, they're more prone to get diabetes, which is about 40 to 50%. They're more prone to get gestational hypertensive disorders like preeclampsia and PIH, and also more prone to get small for gestational age babies. So these are underlying causes: the biochemical hyperandrogenism and hyperinsulinemia. Hyperandrogenism is seen about 60 to 100% of women with PCOS, which can be manifested either by clinically or biochemically. And the excess ovarian androgen production is also augmented by the presence of hyperinsulinemia, as I mentioned, leads to premature follicular atresia and anovulation. And this is why the insulin sensitizing drugs become more helpful in treating women with polycystic ovarian syndrome, as well as infertility. So these women are known to have impaired glucose tolerance and type 2 diabetes mellitus. And of course, as mentioned before, the best test to diagnose these impairments is oral glucose tolerance test. And preferably, but also HbA1c and fasting blood sugar can be used, but with lower sensitivity. Anti-Mullerian hormone is now being used to diagnose polycystic ovaries in the adult group. In the adolescents, as Prof. Helena said, anti-Mullerian hormone or polycystic ovarian morphology is still not used. So the other important thing when it comes to infertility is these women are known to have about 2 to 3 folds higher AMH levels than non-PCOS women. And we know that there is a stronger correlation between the AMH and the antral follicle count. And higher the antral follicle count, the consequences such as ovarian hyperstimulation are higher. So the problem, the core problem in these women concerning infertility is anovulation. And mostly what we do, how we address is by weight reduction, by medication, and also by surgeries such as ovarian drilling. The lifestyle modifications are very important in this category because the weight reduction, even by 5 to 10% in this category, can improve the ovulation rates by 5 to 10%. And also the weight reduction enhances the actions of the ovulation induction agents like letrozole or clomiphene citrate. If the lifestyle modifications are not working, then the next option would be to go for bariatric surgery, such as the vertical sleeve gastrectomy. Usually this is done in women who have a higher BMI, for example, preferably BMI is more than 40 or maybe more than 35 as well. So some women who are going through IVF have gone through bariatric surgery in Sri Lanka, and they have had very much good results after IVF, and they have had healthy pregnancies and healthy babies. So weight reduction is very, very important. We would preferably, I mean, as a fertility specialist, we would preferably would like to have a BMI less than 30, but at least in a woman who has a high BMI, we would like to initially get a weight reduction of 5 to 10% before starting on any treatment. So the effects of weight reduction, it improves ovulation and fertility. It reduces the pregnancy-associated comorbidities. And also the other important thing, if the patient undergoes bariatric surgery, and it can result in nutrient deficiency. So, I mean, these patients should be carefully managed. Probably we might need the help of endocrinologists as well as the medical nutritionists as well. Okay, we'll move on to the medication that we use. The drug of choice for managing these women is, of course, letrozole. The first line drugs are letrozole and clomiphene. Out of those two, the best or the drug of choice is letrozole. It is an aromatase inhibitor used as the first line drugs. Usually in these women, because of the risk of hyperstimulation, we would start with the lowest dose. And if the ovulation is not taking place, then the dose is gradually increased until the maximum dose. In some countries, for example, in United Kingdom, letrozole is off-label for this purpose. So sometimes you may not be able to use it. Or in the case of United Kingdom, what we used to do is we explain it to the patient that the letrozole is off-label. If they are willing to use it, then we can prescribe the drug. Clomiphene citrate. The problems with the clomiphene citrate is that they are kind of more prone to give a multifollicular development. And as a result, the twin pregnancy rate and triplets are comparatively higher when compared to the letrozole. And the ovarian stimulation is also somewhat higher. Overall incidence is less than 1%. Metformin, I think we spoke extensively about metformin. So it's an insulin sensitizing agent. And what it does is when used in combination with other drugs like clomiphene or letrozole, sometimes it may give an additive effect and might be helpful in having ovulation rather than just having a single either clomiphene or letrozole. Inositol is another drug that is commonly discussed nowadays. But of course, at the moment, there is no strong evidence to prescribe these drugs for fertility purposes. But at the same time, there is no harm. So if you are more, I mean, if you like to use inositol, there is no harm in using, but you have to keep in the mind that there is no recommendation or strong evidence for use saying that it would improve the outcome. So we can use either single drugs or combination of drugs. Compared to letrozole, and when we compare letrozole versus clomiphene, letrozole is the better drug. It gives better clinical pregnancy rates. It gives better live birth rates as well. When letrozole and metformin combined and compared against clomiphene citrate and metformin, again, the letrozole-metformin combination gives better results. Letrozole versus letrozole plus metformin, there is no significant difference in the outcome in terms of ovulation rate or miscarriage rate. And letrozole plus metformin versus clomiphene, again, obviously, the combination of letrozole metformin gives better results. So the second line of ovulatory induction agents are the gonadotropins. And the gonadotropins that we use are FSH, either recombinant or purified. In these patients, we generally do not use LH exogenously because they are already known to have higher LH levels. Once the gonadotrophins are used, the important thing is, again, there is a chance that multifollicular growth can occur. So therefore, these women needs to be very carefully monitored to identify either overstimulation or hyperstimulation. And also, HCG triggering will be done only if there are lesser than 2 follicles which are over 40 millimeters or more. But gonadotrophin gives higher clinical pregnancy rates as well as higher live birth rates. So when comparing gonadotrophin to clomiphene citrate, there wasn't a superiority in live birth rate, clinical pregnancy rate, and also ovulation rates per cycle. Sometimes we do combine drugs, but of course it's better to keep the medication simple. I mean, either use gonadotrophins alone rather than combining with either clomiphene or letrozole. But in, of course, our setup, it's a bit different because our patients might not be able to afford gonadotrophins for maybe 10, 12 days. Therefore, sometimes we try to combine it with the oral drugs to reduce the costs. But the best way, of course, is when you're using gonadotrophin is the step-up protocol, the low-dose step-up protocol, where the dose of gonadotrophins are slowly increased depending on the response that is seen in the follicular scan. So this will identify the correct dose that is required for stimulation, as well as we will be able to avoid or control ovarian hyperstimulation syndrome. This is another option, ovarian drilling. Ovarian drilling, I think this was actually first observed. It was observed that women with polycystic ovarian syndrome had spontaneous ovulation after ovarian biopsy. And from about 1980s, this technique was used to treat women who are resistant to clomiphene. Clomiphene resistance is that when you are using clomiphene from 15 to 150, even with the highest dose, there is no ovulation taking place. It's called clomiphene resistance. So if there is clomiphene resistance, there are only 2 options. One is ovarian drilling. The other one is the gonadotrophins. So mostly in Sri Lanka, what we do is we do a laparoscopic ovarian drilling, but this can also be done transvaginally. And it is said that it is equally effective as gonadotrophins to produce ovulation and also clinical pregnancies. So what it does is it causes ovarian stromal destruction, and this leads to a reduction in the steroidogenesis. So this leads to reduction in LH and increase in FSH as well. It is also said that the surgery will improve the blood flow to the ovary, delivering more and more FSH to the ovaries, stimulating the follicles and resulting in ovulation. So efficacy of drilling is variable in the literature. The pregnancy rates may range from 30 to 90% and 13 to 80% respectively when you consider ovulation and pregnancy. Deciding on this technique, there are a few factors we can consider because it gives better results when the LH level is high, or if the infertility duration is less than 3 years, when the woman is less than 35, and when the antral follicle count is less than 50. It gives lower results when the BMI is more than 35, when there is significant insulin resistance and high testosterone concentrations. The other important thing is that it is a destructive procedure. Therefore, it is prone to give rise to post-surgical adhesions. And more importantly, they can have a diminished ovarian reserve and also premature ovarian failure. So mostly the fertility specialists, of course, are not in favor of ovarian diathermy procedures due to these facts. Yeah, so talking about the technique, we are using at the moment the 4-step rule. We are using 4 punctures, 4 millimeters apart for 4 seconds, and we deliver about 60 joules, I think 40 to 60 joules in each puncture. Overall, the ovary gets about 600 to 640 joules, and this is sufficient to produce an optimal response. Of course, the clinical response is higher depending on the energy that is used. Higher the energy used, higher the clinical outcome, but the The problem is that higher the energy use, it causes more ovarian destruction and high risk for adhesions and premature ovarian failure. So these are the complications. So either gonadotrophins or laparoscopic ovarian surgery could be used in women with PCOS who are not ovulating regularly and infertile and are found to have clomiphene citrate resistance with no other infertility factors. But in my recommendation, I would say the gonadotrophins would be the better choice compared to the diatomy procedure. So in vitro fertilization is the next step. Of course, this is the most advanced. And if nothing is working, the next step would be to go for IVF. Problem with PCOS is that they are more prone to get ovarian hyperstimulation. And therefore, the stimulation needs to be very, very carefully monitored. And in cases where there is hyperstimulation, we might need to reduce the dose of stimulation. Sometimes may need to do coasting. The other steps we can take are either using an agonist trigger or going for complete freezing of either eggs or embryos. So there are two protocols in IVF that is used. One is called the long protocol. The other one is the short protocol. In the long protocol, we are using an agonist for downregulation. In the short protocol, we are using an antagonist. In PCOS women, we prefer to go for antagonist protocol, which is the shorter one, because if it is an antagonist protocol, we can use an agonist as the trigger. If it's an agonist protocol, we have no choice but to use HCG as the final trigger injection, and providing HCG to a woman who may be having hyperstimulation features makes the situation worse. And the other thing that I want to add is metformin can be given to these women to reduce the chances of hyperstimulation. But currently, the evidence is only available for the agonist cycle. We don't have evidence for antagonist cycle, but usual practice is, of course, to add some metformin in the dose of about 1.5 to 2.5 grams for these women who are going through even for the short cycle or the antagonist cycle. Yeah. The other, I mean, this is not a novel procedure actually, but it is not widely available. Maybe certain centers like maybe Monash or few centers in United Kingdom has in vitro maturation. What happens in vitro maturation is this is used in PCOS women to prevent ovarian stimulation, because we know one risk factor, one complication of IVF stimulation is OHSS, and sometimes they can go into very severe or critical OHS, which can even be life endangering. So to prevent that happening, the other thing we can do is we can retrieve oocytes at a much smaller stage. We can either use no stimulation or minimum stimulation and retrieve the cumulus, the COC complex when the follicle size is like 10 to 12 millimeters. So the risk of OHS is much lower. And once these eggs are retrieved, they can be incubated in a proper culture media, and then they can be grown into used for fertilization with a sperm. But the problem is in vitro maturation is not so successful at the moment. The clinical pregnancy rates and the live birth rates are much lower. However, with the advancement of the technique, nowadays with the different protocols as well as different culture media, the results are slowly improving. So maybe in the future, in vitro maturation would be a recommended or maybe widely used option for these women with polycystic ovarian syndrome. Thank you very much.
Thank you, David. Very interesting lecture on PCOS infertility and pregnancy. There are a few questions on the dose of clomiphene citrate, maximum dose of clomiphene citrate and letrozole. How much?
I can't hear well, sir.
There are two questions on clomiphene citrate and letrozole. What is the maximum dose you can give for the patient?
So currently the maximum dose is taken as 10 grams a day, 10 milligrams a day. That is 2.5 milligrams, 4 tablets, usually given in 2 doses. Increasing the dose more than that may not give any improvement in the outcome. So that is usually the maximum dose we use.
For clomiphene? There's another question on chloroquine. What is the maximum dose?
Clomiphene citrate, the lowest dose is 50 milligram, and it is, I mean, every 2 cycles. If there's no ovulation taking place, we go to the next step from 50 to 100. And after 100 also, if there's no ovulation after 2 cycles, it's increased to 150. And 2 weeks after 150, if there's no ovulation, it's called clomiphene resistance.
There's another question on when use metformin in PCOS and with ART. Once the technique succeed, how long should we continue metformin with the PCOS?
Yeah, usually metformin can be started at the commencement of stimulation, and it can be stopped at either menstruation or at the time of the pregnancy test, unless there is another indication to continue metformin, for example, like impaired glucose tolerance or diabetes.
So you think the country like Sri Lanka, still there's a place for ovarian drilling in specific case?
Yes, in our setup, sir, we can't afford gonadotropins. I mean, our patients, and the government can't provide. So in that case, maybe we can selectively use for these patients, but we have to be very careful about the energy and the destruction we cause to the ovary.
Can you do it on one side and one ovary?
Yeah, they've done studies on unilateral ovarian drilling and bilateral ovarian drilling. And at the moment, they have found that both are equally effective.
Right. Since we are behind the time at about 20 minutes behind schedule, so let me thank all the 3 speakers, Dr. Jayawardene, Dr. Helena K, and Professor Chandrika Vijayaratne, and she's the one who influenced in organizing this event with Darshan. So let me thank all 3 speakers for their wonderful presentation, and let me thank all the participants. There are more than 100 at the beginning, and from Sri Lanka and from other countries as well. And I wish to thank the Sidus Health for providing the Zoom platform for this event. So again, we hope to see you again in 1 month's time with a similar program. And so far, that's all from here. So good night and see you in another webinar.